So how are you doing?
So before I went to that bone marrow clinic, I was doing fine. I was having a great day. And then I went in there and freaked out. I was so freaked out because they were talking like I needed, like it was imminent that I had to have this bone marrow transplant. And I left there, I was like frozen because I couldn't, like I was in shock because my doctor, Hoffman, had not presented. He did say he was just sending me there because there was a study coming up and just to like check things out, whatever.
Mm-hmm.
But it kind of made me paranoid, like he wasn't giving me a full story because he didn't give me any other choices before I went in. He didn't say that, you know, if this stops working, we can do A, B, or C. He just sent me in there, and they were so aggressive that it blew my mind away. Anyway, so they're doing the testing on my siblings and looking for an outside donor.
Mm-hmm.
So Dr. Hoffman's nurse called me back this morning, and she said that, you know, they just sent me in there, not because anything's wrong, everything's fine, just that they wanted me to find out about transplant for when the time comes.
Mm-hmm.
So that was that story. So
Okay, so not explaining things properly, perhaps, the indication for transplant. Okay.
right, like, yeah, pretty much.
Yeah. And you saw Dr. Singh at the transplant center.
Right.
Okay. Yeah. And he's a transplanter. Dr. Hoffman is a non-transplanter, and he's a transplanter.
Right.
So in this field, when we send patients to a transplanter, there's generally some bias shown towards transplant.
Right.
You know, granted that, you know, they should still look at the indication and the scenario and all that, which I'm sure they did, but
Yeah.
but generally, you know, there is a bias towards transplant, and in that visit they want to educate patients as much as possible about, you know, various aspects of transplant, which I suppose happened there. Now, I was going through this file. Let me show you a test result, which I think you should be aware of.
Okay.
I don't know how much they really explained this to me.
Yeah, I didn't either.
Okay, let's see. You guys can sit down. I'll
Sorry. Hanging over you.
No, it's okay. Okay, where was that? The CT scan looks great, by the way.
Oh, good.
Did they talk about that?
They did. They, let me know that the tumors were shrinking.
The one from July, right?
Yes.
Or have you had one recently?
No, the last one was
Okay.
July. Yeah.
Which I suppose was about, what, 3 or 4 months into the gluten therapy?
Yes, 3 months in.
Which is remarkable.
So thank goodness.
Okay, so I want you to focus on this result. This is the most important result that you should be aware of. Okay, this is basically called chromosome analysis of CLL. From what I remember, you did not have so many changes to your chromosomes
In the early stages.
in the early stages. Okay, you're seeing now you're almost 1.5 lines of chromosomal changes.
Okay.
Okay, that worries me.
Is it still P17 or is it
It is
higher?
P17, and let me point out what others are present now. So you see plus 12. This is another new one that's coming to play. There's one more called 1418. So this is, let's say, 1, 2. Then as we go along, we have 3, something that involves chromosome 17.
Mhm.
And then as we move along, there is one more that involves chromosome 3 and 15. So this is 4. Okay?
Alright.
And then we have one more involving, which is quite, so you have at least 4 changes
Uh-huh.
in addition to 17p right here.
Okay. So the 17p doesn't go away with the medicine.
It does not go away with the medicine.
Mhm.
So, and this was the picture before you started, or at the time you started ibrutinib.
Right.
Right. This was in April.
Oh, okay.
Okay. This was done, I think, around that time or before, or when you were considered for that
Right.
clinical trial.
Yeah, okay.
So, with 4 changes, 4 chromosomal changes, there is clearly the signal that's evolving is that there is clearly there is instability in your chromosomes, okay? And anytime the CLL cells becomes more and more unstable, it acquires the risk of becoming a very aggressive cancer. And in fact, now you fit in the profile of ultra high risk CLL, not just high risk, ultra high risk CLL,
Yeah, they didn't tell
which
me
is the
that.
maximum grade,
Mhm.
okay, of risk stratification that's given for CLL patients.
Okay.
When they have 17P, okay, they are graded as high risk, but now with these changes, you should be upgraded to ultra high risk CLL. So the strategy that's evolving in the treatment of ultra high risk CLL is referral for transplant.
Oh, okay.
Okay, because you want to do transplant when patients are doing well
Okay.
and when they're responding to treatment.
Mhm. That makes
And right now, based on all the numbers and pictures, one could argue that you are deriving the maximum benefit from ibrutinib,
Mhm.
and therefore now is the time to explore alternative therapies to ibrutinib.
Okay.
Because in this scenario, which is defined as complex cytogenetics or complex chromosome changes,
Mhm.
3 or more is complex chromosome changes,
Okay.
ibrutinib's response is not permanent.
Okay.
It's short. And so keeping that in mind, one has to be a little bit vigilant about what's next.
Right.
And there is a movement that patients who are in the transplantable age group, such as you,
Right.
such patients should be transplanted when they're deriving maximum benefit from chemotherapy, whatever that may be. In your case, it's the ibrutinib.
Okay.
So I think that's where probably they're coming from. I don't think they've done a good job of explaining to you.
No.
You didn't get any of this, did you?
Mhm. Well, I mean, the P17, but that was it.
Yeah.
Yeah.
So that's why I think I wanted to give you this information, because I think this is something you need to know.
Okay. Is the 18 higher than the 17?
14, 18. So basically in this case what happens is, I'm going to draw it out here. So you have chromosome 14, okay?
Okay.
This is chromosome 14 and this is chromosome 18,
Okay.
okay? Piece of this chromosome goes here and piece of this chromosome goes here. So there is translocation between 2 chromosomes.
Okay.
Genetic material is transferred between 2 chromosomes.
Okay.
And what that does is it leads to overexpression of a protein called BCL2,
Okay.
which causes aggressive cancer.
Okay.
Okay? Now, you already know that 17P is associated with an aggressive CLL.
Right.
This 14-18 translocation is extremely rare in CLL.
Oh.
And anytime the CLL acquires this chromosome, it brings in additional players like the BCL2 overexpression, okay, which confers more aggressiveness to the disease.
Oh, okay.
Incidentally, there is a drug that just got approved to target this protein for CLL, and that's called venetoclax. You should be aware of that.
Okay.
Venetoclax.
Okay.
And this drug is approved for patients who have seen or failed at least one prior line of therapy in CLL.
Okay.
In your case, Rituxan and ibrutinib.
Mm-hmm.
So you would be eligible for this drug.
Okay.
This drug is approved for patients who have 17p deletion
Mhm.
and who have seen at least one prior line of therapy. And what we are seeing with this drug is we are seeing much deeper responses as compared to ibrutinib.
Okay.
However, we don't have much data on patients who start failing ibrutinib. Okay, how do these new drugs, and there are a few more coming up the pipeline, how do these new drugs really fare? We don't have much data. What we do know in 2016 is patients who start failing ibrutinib, their prognosis is not that good.
Okay. So I need to do something else before it starts failing.
What we also know is patients who acquire these sort of chromosome changes, they are very likely to fail ibrutinib due to some mutations that are acquired in the BTK gene. So Bruton tyrosine kinase, which is known as BTK, is the gene that is responsible for CLL. Ibrutinib blocks this gene.
Okay.
It blocks BTK activity. Okay? Over time, due to all these clones, this gene mutates, or the drug binding region of that gene, it mutates.
Okay.
And then ibrutinib cannot bind to BTK.
Okay.
So basically the mechanism of action is lost.
Right.
And this mutation, based on the research that's published from Ohio State, is more likely to happen in patients who have these clones, multiple clones.
Okay. Yeah. So.
We can preemptively actually check. There are blood tests we can do that, or I can call Ohio State and see whether you have any of those mutations present or not, which would actually make the decision making quite easy.
Right.
However, it should still not change the approach to transplant.
Okay.
And I think you should definitely pursue the donor search,
Okay.
and just kind of be ready, because if you're
Yeah,
doing so
we are.
well with ibrutinib, it's impossible for anyone to perfectly time the transplant.
Right.
And I know it's very difficult for you to reconcile that fact when you're doing so well, and the quality of life is so much better
Right.
than when you hear all the stuff about transplant, which is scary.
Yes.
Graft versus host disease,
There's
you know,
50%
50-50
chance.
50-50
exactly.
chance.
So those are all scary terms.
Yeah.
But I hope this helps you understand why you need to think about transplant. Even if you don't think about now, this is not, it's not like, I don't want to paint the doomsday picture
right.
here, all right? Because there are many new drugs that are coming in the pipeline.
Okay.
Venetoclax being one of them, just approved.
Okay.
There is another drug called acalabrutinib, which would very likely be approved in CLL. And there are these new therapies called chimera-associated T cells, which basically re-engineers the T cells from the patient. Okay, it's basically called T cell re-engineering. We collect the patient's T cells, re-engineer them, put some cassettes into those T cells, infuse it back into the patient, and these T cells recognize the cancer cells much more effectively, go and destroy them. So that's also
Sounds
being
better than a
researched.
bone marrow.
Transplant, absolutely, and it's a one-time treatment.
Wow.
So those trials are ongoing right now if you want to explore an alternative to the transplant
They are available as trials.
as trials.
If you think the chances are good that I'd get in, I guess I'd be open to that, yeah.
Okay, would you consider referral to Bethesda, Maryland, National Cancer Institute, MD Anderson, where?
How long would I have to be going?
Well, basically, you would, ideally, it should be done in a clinical trial. So the first step would be to refer you there and see if you'd be eligible for that clinical trial.
Okay. Johns Hopkins, MD Anderson, yeah.
Okay. I can certainly make those referrals.
Okay.
I can even talk to Dr. Hoffman and say this is the discussion we have had,
Okay.
and